This program is brought to you by Emory University.
All right, good morning, everybody. Welcome to Friday morning conference. As you can see, our speaker this morning is Dr. Ryan Cousins. Ryan is a first-year fellow in our clinical track, undergraduate studies at the University of Virginia, Medical School, Eastern Virginia, School of Medicine, came here for residency here at Emory. And as you can see on the screen, he is going to talk to us today about carcinoid heart disease. Take it away, Ryan.
All right, thank you very much, Dr. Williams, and thank you everyone for attending. Good morning. I'm looking forward to talking about a topic I didn't know quite much about a month or so ago, but looking forward to sharing with you today, and that is carcinoid heart disease. So I have no financial disclosures or conflicts of interest to present today. So there are three main objectives I want to make sure we go through for this presentation. The first is to make sure we have a good understanding about the pathophysiology and natural progression of carcinoid heart disease, especially when it kind of comes to the right side of the heart in the setting of carcinoid syndrome. Second is to kind of recognize and accurately describe what you would see on transthoracic echocardiography with carcinoid heart disease. And then finally, especially for my co-fellows, if you see a patient like this in your clinic, kind of developing a mental algorithm for how you would manage them in the outpatient setting and know at what point these patients should be referred for valvular repair with regards to their progression of carcinoid heart disease. So in terms of the outline of this presentation, we'll first start with the clinical vignette that I'll kind of periodically continue to go through and touch upon throughout the presentation. We'll talk about a little bit of an overview of neuroendocrine tumors all the way to carcinoid heart disease, the pathophysiology, how we diagnose and kind of surveil these patients in the outpatient setting with regards to presentation, biomarkers, and echocardiography, which will be the most significant portion of this presentation. Touch upon a little bit of pharmacotherapy, surgical valve repair, and finally the most important take-home points from the presentation. So we'll take it all the way back to 2014 when our patient first presents to the outpatient cardiology clinic. She was diagnosed with neuroendocrine tumor of the pancreas in 1999 at age 53, and she's currently 67. She's on chronic octreotide therapy, and she said, my oncologist told me to come to the cardiology clinic because they told me to get a heart ultrasound, and I was told it was abnormal. What does that mean? What should I do? In addition, she's got CKD3, chronic anemia, some hypertension. With regards to the history of their present illness, from a cardiac standpoint, besides occasional abdominal pelvic discomfort and some hot flashes here or there, she actually denies having any cardiopulmonary symptoms at this time, despite having had this disease for about 15 years. She's got no chest pain, no dyspnea, no edema. For kind of rounding out her history, she's got negative cardiovascular disease in her family and denies drug and alcohol use. Hemodynamically, she's kind of standard across the board. She is a bit more on the shorter stature side at 4'2", 106 pounds at this time. And on examination, she has a slightly flushed face. Cardiovascular-wise, you do hear a 3 out of 6 systolic murmur toward best the left lower sternal border. No prominent JVD, although we hypothesized that at this time, based upon the echo, which we'll go through in a little while, that she probably would have had pretty prominent Canon V waves if you were able to kind of tilt her back on her physical examination. Lungs were clear, no peripheral edema. Overall, actually looked pretty good. No, unfortunately, at this time, in terms of lab work, she had no BNP or carcinoid biomarkers that we'll discuss a little bit later on too as well. But overall, fairly doing okay. So again, also more for my co-fellows here, if you see this patient in the outpatient setting, I want you to kind of think about what you would do with her at this time. What would you expect to see on her TTE that oncology recommend that she get? What would you do in terms of her current management? Would there be any other additional cardiac tests that you would do for her, any other lab work? And most importantly, if this patient asked, hey, what should I expect kind of going down the line with regards to this carcinoid syndrome in my heart, what would you be able to tell her in terms of her prognosis? So now kind of going into a general overview of neuroendocrine tumors. First, I want to touch upon and say that the vast majority of everything that I'll be discussing was heavily influenced by the 2017 ACC expert statement that was released with regards to carcinoid heart disease, primarily focusing on the diagnosis and management of these patients. So carcinoid tumors. So these are actually now referred to as neuroendocrine tumors, or NETs, and this changed in 2000 to give them a bit more specific, better name in terms of their origin, in terms of neuroendocrine. And primarily, they secrete vasoactive substances, primarily serotonin, or 5-HT, that cause a vast array of systemic symptoms that we'll talk about in a little bit. And these occur if the substances are not cleared by first-pass metabolism of the liver. Interestingly, the word carcinoid was actually coined in 1907 by a German pathologist, Oberndorfer, because it was carcinoma-like in that it displayed benign clinical behaviors despite looking malignant in terms of the microscopic appearance. Importantly, too, in terms of site of origin, about 70 to 80% of these tumors you'll find of the origin will be in the small intestine, in the ileum, and the proximal colon. Our patients came from the pancreas, but you can also see it in the foregut with the stomach and the lung, or more rarely in the hindgut with the distant colorectal tract. These are normally slow-growing tumors, but again, once they metastasize to the liver, that's when you'll see a lot of these symptoms. And that's when you're going to get carcinoid syndrome. So when the vasoactive substances go to the rest of the body, you'll see episodes of flushing, vasoactive hypertension, diarrhea, and bronchospasm. And again, this occurs when they bypass the liver in terms of first-pass metabolism. In this case, it's the carcinoid heart disease. Once all these substances kind of reach the IVC and go to the heart, you'll end up having progressive right-sided dysfunction, primarily with the tricuspid valve and the pulmonary valves. And that's because of overexpression and overexposure to serotonin when you develop plaque-like fibrinous endocardial thickening, leading to valvular dysfunction. Interestingly, about 85% of patients, once you get to carcinoid syndrome with liver metastasis and uncontrolled carcinoid syndrome, will develop carcinoid heart disease, and rapidly for about greater than 50% of these patients. Why is it important for us to make sure we recognize carcinoid heart disease early on? Is that the 3 years of survival for this, if not recognized, is fairly poor, about 31% compared to 68% for those with compared to without carcinoid heart disease. And I'll be referring to carcinoid heart disease as CHD, and you'll see it written as CHD throughout this presentation to kind of avoid confusion. So it's a major source of morbidity mortality for these patients. This has actually gotten better over the course of the past few decades with regards to increases in terms of advances in cardiac imaging, anti-tumor therapies, specifically valvular replacement, but this is still something that's important to make sure we catch early on. So just kind of a graphic in terms of what we just briefly talked about. So you got your neuroendocrine tumors on the top left that secrete serotonin from a tryptophan base that'll spread to the liver for carcinoid syndrome. It'll be metabolized to 5-HIAA, which we'll talk about later. And then these substances, once they spread to the rest of the body, toward the heart, you'll see all these kind of vasoactive symptoms in addition to what you'll see from carcinoid heart disease. And this slide just kind of shows how rare this disease truly is. In the general population, you'll have 2.5 to 5 cases per 100,000 that'll develop neuroendocrine tumors. 30 to 40% of these patients will develop the carcinoid syndrome in terms of metastasis, and then 20 to 50% will develop carcinoid heart disease all the way down the line. We're talking a little bit more about the pathophysiology of carcinoid heart disease. And there's 4 main areas I want to discuss, primarily first with the valvular heart disease, and then we'll kind of go around the wheel here in terms of other additional findings that you'll see. So as I talked about, the tricuspid valve and pulmonary valve, when they get exposed to these vasoactive substances, primarily serotonin, with these 5-HT2 beta receptors, it'll induce fibroblast generation, growth, collagen synthesis, all within an inflammatory cytokine microenvironment that will lead to loss of integrity of these valves and worsening heart function, especially on the right-hand side here. So it's deposition of these plaque-like materials, like we discussed, that you can not only see on the valve itself, but you can also see it eventually on the chordae tendineae, the papillary muscles, and the cardiac chambers themselves. So it's not just the valves that are involved. 90% of the time, due to the regurgitant flow that you'll see throughout time, is that you'll see that these will deposit on the ventricular side of the tricuspid valves, followed by the pulmonary arterial side for the pulmonary valves. And as briefly mentioned, this is primarily a right-sided disease. However, if you do have certain instances of right to left shunting in terms of a patent foraminal valley or PFO, if you have a primary bronchial carcinoid, because the lung also does participate in this metabolism of the serotonin, or if you just have extremely high tumor burden and high circulating serotonin levels, you can see this eventually pass to the left-hand side. So it is important to make sure we take a look at the left side of the heart here too as well in terms of the valvular structure with regards to evaluating these patients. Moving on to coronary artery disease. Now, interestingly, with regards to increase in serotonin exposure, you can actually have either vasoconstrictive or vasodilatory responses depending upon the native architecture and of your coronary arteries and how much endothelial damage they may have in the beginning. So again, due to these 5-HT2 receptors that you'll see in the coronary arteries, sometimes patients will present or have a complication of almost like a Prinz metal angina type picture with these complications from the serotonin. And if it's significant enough, with a third bullet down here on the screen, you can actually end up having stent thromboses just because the serotonin increases platelet activating properties if you have enough going to the coronary circulation. So something to kind of be aware of and keep in mind for these patients. Next is arrhythmias. So this is something that will periodically kind of pop up every now and then for these patients. It's primarily more due to, again, the serotonin leading to kind of sympathetic discharge and activation of everything here with regards to maybe having increased tachyarrhythmia, specifically like SVTs. These are relatively rare within the context of not having any other significant heart disease and rare in isolation. So more often than not, if you have patients with these arrhythmias, they do respond fairly well to beta blocker therapy. And finally, direct myocardial involvement. So even going one step further down on the ladder that I showed you a little bit earlier in the presentation, you can sometimes even have direct myocardial metastasis from the carcinoid syndrome of wherever the primary tumor may be. And this actually will correlate fairly well with higher tumor burden overall. And so what you're going to see here is well-circumscribed, homogeneous, non-infiltrative metastasis to primarily the ventricles, which can sometimes, if it grows large enough, can actually cause a physical outflow obstruction. Now, sometimes you can see this on echocardiography, which we'll get to in a little bit, but PET-CT is primarily the best and more sensitive at detecting these lesions, especially if they're less than 1 centimeter compared to what you'll see on echocardiography. An important point to note, though, is that just because there's increased tumor burden in terms of metastasis, the effects that you'll see from serotonin and the vasoactive substances within the heart is actually a completely separate entity. While you're a bit more at risk for that if you have myocardial metastasis, each individual patient's tumor and the spread of that serotonin to the rest of the heart, again, is kind of what impacts more of the change, not necessarily the presence of the tumor itself, which I thought was very interesting. Okay, so now I'll go ahead and jump into the initial presentation for these patients that you may see in the outpatient setting with regards to diagnosis and surveillance. So when patients are diagnosed with carcinoid syndrome, you can actually see that the presentation of these symptoms, which are primarily, as you can imagine, will reflect right-sided heart disease, can be extremely subtle. You may early on for these patients see when they come in and refer to you, especially hopefully if they've had their initial echo, is that, you know, honestly, maybe less than 50% may complain of a little bit of dyspnea at rest or with exertion, a little bit of fatigue. You may see some prominent JVD or those Canon V waves that we talked about. You may hear a murmur, you may not. Interestingly, for patients that end up having moderate, even to severe tricuspid regurgitation, only about 30% of these patients may actually present with significant enough symptoms for you to be able to recognize it. And only 50% of the time, you may even hear a murmur. So the importance of this slide is to basically indicate and mention that having a high clinical suspicion for what you're expecting to find in terms of carcinoid heart disease, or knowing that, especially early on, patients may not be quite symptomatic, but if they do have carcinoid heart disease that's developing, as we mentioned earlier in the presentation, that if left untreated and if these patients are not followed pretty frequently, that this can deteriorate fairly rapidly. So again, it's important to have a high clinical suspicion when if you may ever see a patient like this in your clinical practice. Next, kind of moving into biomarkers here. So there are 2 biomarkers that have been found to be very kind of useful in terms of not only the initial diagnosis of carcinoid heart disease for these patients, but also the kind of surveillance of therapy and treatment and the prognostic significance. And so those two are going to be BNP or N-terminal pro-B type natriuretic peptide, and then 5-HIAA or 5-hydroxyindole acetic acid that we mentioned is kind of a byproduct of metabolism in the earlier slides. So starting more with BNP. Again, it's significant in that it's great for both the diagnostic kind of indication of whether patients have carcinoid heart disease, and then monitoring this periodically shows how significant there may be in terms of cardiac involvement. So they've developed a cutoff of about 260 picograms per milliliter, and that actually ended up having a sensitivity and specificity of 92 and 91% respectively for patients who are diagnosed with carcinoid syndrome if they have carcinoid heart disease. Now moving next to 5-HIAA. So this is a metabolism byproduct. You'll see it in the plasma, but usually in terms of monitoring this in the outpatient setting, this is most significant for patients in terms of monitoring it for their urinary levels. And this is correlated fairly well in that significantly higher markers of 5-HIAA in the urine correlates with patients who have carcinoid heart disease and how much of the involvement that they have. So this level of 300 millimoles per 24 hours of urine samples then conferred a 2 to 3-fold increase in the risk of developing and progression of carcinoid heart disease. So in the outpatient setting or in the oncologic setting, when we're monitoring these patients in terms of the therapies that they're on that I'll go through in a little bit, aiming for a marker of less than 300 for these patients is crucial in terms of preventing that progression like we talked about. Now, the utility of these tests, can be limited by several different factors. One that's most important is, ease of patient use. They have to kind of collect their urine for 24 hours and make sure they do it correctly. And actually, different food and drug intake can alter the levels of these 5-HIAA assays with regards to foods that are high in tryptophan, such as bananas, tomatoes, avocados, will actually elevate your levels of serotonin byproducts in the body, and can lead to false positive or false elevated levels of 5-HIAA. And interestingly, aspirin, a very common medication that a lot of different patients take for various cardiovascular reasons, whether they should or not, can lead to reduced platelet release of serotonin that can lead to a false negative or a lower than expected value of 5-HIAA. And finally, on the bottom here, other glycoproteins such as chromogranin A, activin A, are used in clinical practice, although not quite as much because their specificity is not quite as good as these other two, even though they are sensitive. But you can throw them in here too as well in terms of other biomarkers to use. Okay, kind of finally jumping into more of the meat of this presentation. What would you expect to see on transthoracic echo for these patients? And then we'll jump into the progression from 2014 up until now of what this patient's echocardiographic progression has looked like in terms of her carcinoid heart disease. So jumping now into the present day. So this is about a month or so ago when I first got introduced to this patient. So in the clinic, she's been mentioning that over the past few months specifically, she's now finally developing these right-sided heart failure symptoms. She's having progressively worsening bilateral lower extremity edema. She's got dyspnea on exertion, even some orthopnea. She's been seeing nephrology because her kidney function is getting worse, and they've actually been, they prescribed Lasix for her. Despite that Lasix therapy, she's still developing these symptoms. From a hemodynamic standpoint, she, across the board, still looking relatively well. She, although has lost some weight here too over the past 8 years or so, at 99 pounds now for a BMI. It still equates to about 28, but it's because she's 4'2". From the physical examination standpoint, you're kind of seeing, the development of what she's mentioning in her history kind of coming into fruition here. Still has a slightly flushed face that was documented, but she's now got worsening pansystolic 5 out of 6, murmur that's also still heard best, the left lower sternal border. JVD is quite more prominent now. At 9, she's got some bibasilar crackles, 2+ bilateral pitting edema, and a little bit of abdominal kind of distension here too as well, a little bit tender there. And then towards the bottom here, you'll see that we now have some of these biomarkers that I was briefly mentioning previously coming on through. So at this time, her BNP is 202. So not terrible, but still, decently elevated, especially more in the setting of her body habitus. Her 5-HIAA levels in the setting of her chronic lanreotide therapy that she's been pretty compliant with. 6.5 milligrams for 24 hours. The normal is less than 6. So she's doing fairly well with that. But with regards to the chromogranin level that we briefly discussed, this is significantly elevated at 17,500 compared to a normal value of less than 311. And specifically jumping into the imaging findings for what you'll expect to see, this is then heavily influenced by a little bit more of a recent set of guidelines from the ACC in 2021 as well, specifically JACC cardiovascular imaging with regards to not only just the advances, but the specific parameters and things we should be looking for patients with carcinoid heart disease, specifically with echocardiography, but also with regards to cardiac MR, CT, and nuclear that I'll briefly touch upon here too as well. A very, very brief note in terms of the basic kind of diagnostics that we use every day in terms of chest X-rays and EKGs. Now, the sensitivity and specificity for both of these are a little bit more on the lower side. With significant progression of disease, you may end up seeing low voltages on your EKGs, primarily more due to pericardial effusions or pleural effusions that may develop. And then on chest X-ray, you may see an enlargement of the cardiac silhouette just due to the advancements of the heart failure. But again, this is more just kind of something you may see, but not necessarily too helpful overall. And moving on to transthoracic echocardiography. So this is by far and away the gold standard for not only the initial diagnostic evaluation and severity of patients that you're suspicious that may have carcinoid heart disease, but definitely the surveillance of progression in terms of how well your therapy is working and how the heart is responding to the therapy. It's got several different advantages, which are pretty intuitive. It's very easy to use compared to CT, MR, nuclear. For what it's worth, there's lack of radiation exposure compared to CT. You don't have to worry about for patients with other cardiac devices with regards to MRI in terms of contraindications for that, even though with the more modern devices, those are becoming fewer and fewer in terms of concerns, but still something that you don't have to worry about. And what's always nice about echo is that not only do you get a great morphologic view of the heart, but you're also getting that dynamic hemodynamic assessment all in one. So as I was mentioning here, you can see that carcinoid heart disease will vary from a vastly different spectrum in terms of very mild isolated thickening of that tricuspid valve and even just a single leaflet, especially early on, to significant reduction in terms of the valvular mobility, significant thickening, retraction, multiple valves that are involved, and significant right-sided heart failure symptoms. So starting more specifically with the tricuspid valve. So as I was mentioning, you're essentially going to see a large subset of different findings on a great spectrum here. So the biggest thing to look for is essentially thickening of those valve leaflets. And again, you can see that on the subvalvular apparatus with regards to the chordae, as well as the papillary muscles, because of all of that deposition of that fibrinous material from the serotonin and that buildup and that inflammatory microenvironment. The curvature of these leaflets and their normal architecture will be destroyed. So now instead of moving in a nice undulating pattern, you'll see they become very stiff and board-like in terms of how they move. Like I mentioned, that dynamic motion, especially during systole, is off. You'll have fusion and shortening of the chordae that leads to even more dynamic abnormalities. And then what does all this kind of account to? Well, you're going to have significantly progressive tricuspid regurgitation that can lead from mild all the way up to severe, and this can actually happen fairly rapidly. The pulmonary valve, which is the next biggest culprit that's involved, will have a very, very similar trajectory from what you're going to see in terms of the tricuspid valve. Like I mentioned, thickening of the valves, straightening of the cusps, it's fixed, retracted, not able to function in the way it normally should. You'll see some annular dilation here too as well. But there are two important key points I want to make sure I mention with regards to transthoracic echo and the pulmonary valve. One is that, as we've seen going through a lot of echoes here ourselves, is that there are limited views that you can get to really even have a great view of the pulmonary valve And the vast majority of the time, in terms of evaluating this valve the way we really need to in terms of this setting, it can be very difficult to get that valve into the right plane to monitor in terms of structure as well as function with regards to spectral Doppler here. So that's number one. It can be very difficult to kind of get an accurate assessment for this in terms of transthoracic echo. The second is not only is it difficult just from a parameter standpoint of the constraints of transthoracic echocardiography, but when you have significant, moderate, especially up to severe tricuspid regurgitation, the flow across that pulmonary valve is going to be altered significantly. So it's in the setting of the tricuspid valve also malfunctioning that it's very, very difficult to kind of determine how significant the pulmonary involvement is. And we'll have to have other imaging modalities I mentioned a little bit later on to get a better picture in terms of how this pulmonary valve is truly functioning. Just a quick word in terms of the chambers themselves on the right-hand side, as you can kind of intuitively imagine, if you've got significant development of regurgitation in terms of that tricuspid valve, pulmonary valve, you're going to have progressive dilation of the right atrium and the right ventricle, which can then lead, of course, to reduced systolic dysfunction and progression of those right-sided heart failure symptoms that we already mentioned several times here. Now, with regards to the left-hand side, as I mentioned before, there are instances where if you do have right-to-left shunting from a PFO or some other atrial septal defect, a high burden, tumor burden that's actually more prominent in the lungs, or if you just have a high systemic serotonin burden, you can see the left side of the valves become more involved. But again, this is going to be all leading to, thickening of those valves, poor mobility in terms of their inherent movement. They're going to be fixed, retracted. You're going to start to see that regurgitation on both sides here too as well, unfortunately. The one other key important point to mention about this, though, too, as well, on the bottom of your screen here towards the left, is that all of these TTEs, especially initial ones, should have agitated bubble studies to look for the presence of any patency between communication from the right to the left-hand side for all of these progressive changes you may see on the left here too as well. Okay, I hope these videos come through fairly well for you, but we're going to jump into the echocardiographic progression of this patient's echo. So this is when she first got her full set in July 2014. This first view is a rivet view or right ventricular inflow tract view. One on the left is 2D. The other on the right is going to be your Doppler. As you can see, she's got a significantly dilated right atrium, right ventricle. The tricuspid valve leaflets themselves, you can start to see the thickening more proximally. The movement is still fairly okay and intact, but still you can still see some decent restriction here. And then with the color flow on the right, you can just see that she already in 2014 has significant, moderate, if not severe, tricuspid regurgitation, very, very impressively here on the right-hand side. And this is a color flow Doppler of the same picture that we just saw in the previous slide here. And as you can see from the arrow or the crosshatch mark here, that is a bit more overestimated, but you can see more properly at the envelope here that she has a regurgitant speed of close to 2.5 meters per second across that valve, which is extremely impressive. And this is a next slide of a basal short axis view that we're going to be looking specifically more at the pulmonary valve with. And as you can see, it's a little bit difficult to still kind of see the architecture of the pulmonary valve. You do see some of those changes that I was briefly mentioning earlier kind of coming on through. But with the red flow of blood towards the probe here, you'll see that she still at this time probably has mild to maybe moderate pulmonary regurgitation here too as well. But again, it's very difficult to kind of properly quantify this in the setting of tricuspid regurgitation, but overall still very impressive. And again, a color flow Doppler kind of coming on through that pulmonary valve that shows that she even has kind of close to maybe 50 to 75 centimeters per second in terms of that regurgitant flow across that valve. And this is all back in 2014. Now, in 2017, so this is not to present day of the most recent time we've seen her in the clinic, but she actually ends up getting admitted to the hospital because she has an angioedema type reaction to lisinopril. And the primary team at that time, intuitively enough, were saying, hey, it's been 3 years since you've had your last echo. We know you have carcinoid heart disease. Let's go ahead and get another one because you're also now presenting with some slight peripheral edema. But she says also at this time that it's very minimal. Nothing is limiting her physical activity. She doesn't have any dyspnea, but she's now starting to slowly develop some of those right-sided heart failure symptoms like we mentioned. But here, if you can remember the rivet view from previously about 3 years ago, this is another rivet view that we're seeing here, right atrium on the bottom, right ventricle on top. And most prominently and importantly, you can see as this video continues to play, that these tricuspid valves are extremely more prominent, very thickened, and their mobility is incredibly reduced. It's essentially, the gate is essentially wide open, unfortunately, in terms of the communication between these two chambers, which is leading to significantly worsening regurgitant flow here. And finally, about a month or so ago is when we saw her last in the outpatient setting to monitor for her symptoms, in addition to sort of where we are with regards to the carcinoid heart disease. And this is an extremely similar view of the rivet that I showed about 3 years earlier in the previous slide. And here, you can see that these leaflets are incredibly more prominent in terms of their thickening and retraction. The anterior and posterior leaflets are not moving whatsoever. The dilation of the right atrium and right ventricle is very similar. But what's even more impressive, I think, in this shot is that you're starting to see incredibly thickened, retracted, and limited movement of the chordae and a little bit of the papillary muscles coming on through here too as well, which again, this gate is extremely just wide open, and you can see prominence of the thickening, now more of the subvalvular apparatus that we were talking about earlier. And this is just a color flow of that same area. And you're just showing that that tricuspid regurgitation is filling the entire right atrium here. And it's just incredibly impressive of all of that turbulent flow kind of coming back and forth across that valve here. And so this next shot is another continuous wave Doppler of that rivet view that we just saw in regards to kind of trying to quantify the tricuspid regurgitation. And the important point I wanted to get across for this is that when you're looking for for tricuspid regurgitation, you're normally, if you're looking towards the bottom of the screen here in terms of the regurgitant flow, you'll normally see a nice parabolic, evenly kind of distributed flow across that valve when the regurgitation is not towards, it is less than severe. However, when you have significant driving pressure forces that are reduced fairly quickly because of all that increased pressure in the right atrium, you're going to be seeing really high peak of this regurgitant flow and volume that then will come down very significantly. Instead of being parabolic, you'll see what's kind of classically defined as almost this dagger shape that you'll see in terms of this tricuspid regurgitation, and that's most significant for this being severe in terms of all this TR. And so moving on to evaluating the pulmonary valve a little bit more. So again, this is basal short axis view shot trying to look at that. And what you'll see now is that she's got definitely a lot more impressive, especially with the end of the still frame here, of the pulmonary valve in terms of the regurgitant flow across that, with all of this red directed flow back to the probe here. And we are suspicious now that the progression of her symptoms, especially over the past few months that have clinically been deteriorating, are more likely than not probably due to the fact that her pulmonary valve and pulmonary integrity is now starting to finally get worse here too as well, unfortunately. Interestingly enough, though, I failed to mention that from 2014 to 2017 to now, her right-sided systolic function has actually not reduced too significantly. It's been able to keep up with all this regurgitative flow fairly well, surprisingly, which may be another indication and reason as to why she's done so far fairly well for having had this disease for such a long time. And this is just another kind of color flow Doppler of the regurgitant pulmonary valve volume. And what's interesting to note here too as well is the regurgitant volume will be going towards the probe here in this shot. And you'll see towards the center of the screen with my mouse here that you'll actually, the flow across that valve in terms of the regurgitant flow actually will go to zero in kind of mid to later diastole here before you even see the systolic forward flow here. And again, this sort of gap in between here is fairly indicative of the severity of her pulmonary regurgitation here. So overall, incredibly impressive echogenic findings. And last but not least, on the right-hand side here, you're going to see the picture of her IVC. And what we're looking for here is in the setting of significant tricuspid regurgitation is the flow reversal of all the blood kind of flowing through that hepatic area. And so whenever you see that red instead of the blue kind of coming through the IVC and the hepatic vein here, that's when you know that your tricuspid regurgitation is more on the severe side. And again, kind of seeing that in terms of your pulse wave Doppler here on the left, you should not be seeing all of these kind of forward-looking sort of peaks here with regards to that flow. So that's indicative of the hepatic flow reversal. Okay, so that's everything for TTE. Kind of now briefly mentioning other imaging modalities here, which do definitely have their place in terms of monitoring and diagnosing these patients in terms of their carcinoid heart disease and their severity. So again, when the windows are poor, especially when evaluating that pulmonary valve, CT and especially MR can be very, very useful in terms of getting a better, not only picture of this valve, but moving on to the second bullet point here, you're going to be getting a lot better and more accurate volumes for regurgitant fractions and regurgitant flows and ventricular function here too as well, which is important, especially when it comes to kind of pulling the trigger for when these patients should be getting valvular repair. In addition, cardiac CT, especially CCTA, can be useful for evaluating the coronaries whenever these patients may be, needing some sort of valvular repair or hepatic surgical intervention here too as well. You can get those done at the same time. And then for MR and kind of PET CT here too, like I was mentioning briefly, these are going to be a little bit better in terms of detection of any potential cardiac metastases from this carcinoid syndrome here. So as you can see on the left in this picture A, that this is just sort of like the scenario snapshots of getting all the different specific volumes in these cross sections here with cardiac MR that's going to be able to give you the better calculations of these volumes, these regurgitant flows, to then give you a better picture clinically, especially in terms of how the right side of that heart is doing. And then B is just an example of a cross-sectional view of the pulmonary valve here that you can see that if this were able to play, that you can see the prominence of the thickening of these pulmonary valves here and kind of how wide the area in between these two actually is. And finally, nuclear medicine. So interestingly enough, what nuclear is able to do is actually take advantage of the significant somatostatin receptors that you're actually going to see that are overexpressed on these carcinoid tumors that you can then have radio-labeled somatostatin analogs that bind to these tumors and that'll light up fairly well with regards to seeing and making sure there's no evidence of any additional metastasis here too. But again, just to kind of bring this point up back one more time, this, while it correlates with tumor burden, does not necessarily always coordinate with the pathophysiology of the valvular heart disease and the serotonin overexpression itself as well. These are two separate entities, even though they do have some correlation. So this is a nice, beautiful picture of what you would see in terms of that nuclear study. We've got just the prominence of this carcinoid syndrome, neuroendocrine tumor metastasis to the heart here too as well. Okay, and now just kind of touching upon briefly some pharmacotherapy, and then when do we pull the trigger for these patients with regards to surgical valvular repair. Now, this is just a brief overview of kind of the workflow that more of a primary care physician may do in terms of like seeing these patients in the outpatient setting. So once the patient's been diagnosed with metastatic neuroendocrine tumor to the liver, and they've got that, they've kind of passed that first gate, that first pass metabolism, well, go ahead and get a good clinical history for these patients. See, are they experiencing and having any right-sided heart failure symptoms? What's their BNP? How well are they doing kind of overall? If your BNP is less than 260 and they're doing fairly well, you're not suspicious of any right-sided heart disease, I still would probably get a baseline echo just to kind of have our baseline in terms of progression for that. But if you have that echo and these patients doing fairly well overall, you can actually kind of follow them up with 6-month echoes in the clinic here. However, if their BNP is elevated, they're showing signs or symptoms of kind of CHD that's been progressive, or their carcinoid syndrome is not being fairly well controlled, then this is where you get a little bit more kind of on the ball of getting these patients evaluated appropriately. So this is when you would likely refer these patients to cardiology, if not sooner. And again, if they have carcinoid heart disease, refer to cardiologists with an expertise in CHD. If there's no CHD, but there is pathology on an echo, of course, refer to a cardiologist in general. If there's a normal echo, this is where we continue to follow up with BNP and symptoms and kind of go back to the start here. So what should we be considering in terms of patients that have some progression of their carcinoid heart disease and you're evaluating them for therapy, medical therapy, or surgical valvular replacement? So it's important to make sure we kind of keep a good eye on, what's the clinical status of how these patients are doing overall. How well are we taking care of their tumors? Are these progressing, or is it stable? What are their other comorbidities in terms of involvement from carcinoid heart disease or carcinoid syndrome, or just overall in general? And again, how well are we treating their symptoms from carcinoid heart disease? Briefly just touching upon heart failure, there's nothing kind of new or special with regards to the treatments for these patients with their right-sided disease. As we all kind of well know, treating the volume is especially important for these patients, but just kind of keeping an eye on making sure that you don't deplete them too much in terms of their volume, because they may be a little bit depending upon their right-sided heart function. I'm just going to touch upon, there's a lot of words on these next few slides, but I'm not necessarily going to be going into them into too much depth. This is more so that if you take care of patients in the outpatient setting, you may have a general idea in terms of what they may be on from a symptom standpoint with regards to their carcinoid syndrome. Most specifically from the first bullet point, somatostatin analogs. These are the first line pieces of therapy that will help try to reduce the burden of serotonin. So what somatostatin does is it inhibits the actions from serotonin. It's almost kind of like the complete opposite of what it does. So you can have longer acting forms of octreotide and lanreotide. Like I said, these are the first line mainstays of therapy, and it's more of an anti-proliferative effect. And this will work fairly well to 60 to 70% of patients. Now, the last two, interferon alpha and telotrestat, are kind of newer advances in terms of these therapies. They're more second line if the somatostatin analogs aren't quite doing the full job here. And interferon alpha works by kind of inhibiting the proliferative microenvironment too as well in terms of the serotonin release from these cells. And telotrestat is more of a small molecule inhibitor that actually prevents the synthesis of serotonin specifically itself in the first place. These next two are a bit more advanced in terms of types of different therapies that you can use for these patients. So the first bullet point of peptide receptor radionuclide therapy, this essentially just uses, kind of like what the name implies, radionuclide therapy to target these cells, kind of prevent their growth and metastasis and serotonin secretion. And then on the bottom, TAE, which are and surgical debulking, which are more kind of minimally invasive procedures to kind of attack, especially when the carcinoid syndrome gets to the liver, prevent these from getting worse in terms of tumor burden. The most important point about these two, though, is that it kind of emphasizes the point of making sure we catch CHD very early on, because if these patients have worsening right-sided heart failure symptoms and cannot take the amount of volume that comes with the peptide receptor therapy, or their RV dysfunction is so poor that there's a high probability of adverse events with the bottom for TAE and surgical debulking with the perioperative high mortality because of the liver with increased right atrial pressures, that, again, these therapies could be off the table, unfortunately, for these patients if we don't catch the CHD early on enough. So then finally moving into surgical options. So valve replacement has become by far and away the most important and most useful therapy for advanced CHD. And the survival benefit is significant here, about 40% at 2 years once they get that valve replaced, specifically primarily more the tricuspid valve and any other valves that may be involved, compared to 8% for those with severe CHD. And again, you're primarily focusing on that tricuspid valve first because that's the one that's most involved. However, if you see decline of any of those other heart valves, if there's no other contraindications to replacing these valves, that surgeons will generally try to favor also replacing most of these valves as well, just to prevent this progression from getting any worse. Something I thought that was really interesting here too as well, for the final bullet point, is that tricuspid valve replacement for CHD has actually become and evolved to be the most frequent indication for tricuspid valve replacement over the past 2 decades specifically. So again, what kind of indications are we looking for valve replacement? Well, this essentially becomes for 2 different reasons. One, despite medical optimization for not only right-sided heart failure symptoms, but also the carcinoid syndrome in general, are these patients having refractory right-sided heart disease and syndromes in terms of fatigue, dyspnea, and peripheral edema? And or based upon your imaging, are you seeing that the right ventricle, unfortunately, is finally getting to the point where it's just not able to function and keep up? These are the two most important indications in terms of when patients should be referred for valvular surgery. Now, what kind of valve should we use? Well, there's still a little bit of debate, especially over the past kind of decade or so, in terms of whether it should be a bioprosthetic versus mechanical. Initially, early on, there was debate because, especially with the bioprosthetic, that the serotonin exposure could still lead to kind of worsening of these bioprosthetic valves in terms of the deposition and kind of the process starting all over again here. However, most recently, with kind of advanced in terms of the therapy for carcinoid syndrome, bioprosthetic valves are now favored over mechanical valves. Most importantly, when you can control that serotonin overexposure. And again, this is most important more for the setting of anticoagulation than anything else. Not only is it kind of just easier for the patients to kind of be compliant with their valve. They don't have to be on warfarin for an extended period of time, but also just because if there's any other additional interventions that these patients may need, especially with regards to the liver, well, when you're in such an environment where the coagulopathy because of the liver, anything that could be better in terms of reducing that, is always good. One other point to kind of mention is that whenever you're dealing with these patients perioperatively, almost kind of like when dealing with patients with pheochromocytomas, that you have to be very careful with the potential release of the serotonin and other vasoactive substances that can be essentially going with something called a carcinoid storm. So you actually end up having to give these patients an octreotide infusion before, during, and potentially even after to prevent this from happening when you do intervene upon these patients, not only for their valve replacement, but also maybe for any sort of like liver debulking therapy. And finally, for these patients, regardless of whatever valve they get, they still have to be on anticoagulation, specifically warfarin, for 3 to 6 months for this afterwards. You should be getting an echo, immediately after they get this done. Within the first month they get to get done, and then if everything's going fairly well, you can spread it out to 3 to 6 months and then 6 to 12-month intervals. And last but not least, which is very important, it's important to make sure we control that carcinoid syndrome like I was talking about briefly previously in terms of getting that 5-HIAA level less than 300 micromoles per liter here. So lastly here, this is more of the flow chart for us as cardiologists in terms of when we have a patient that has confirmed carcinoid heart disease, how should we manage them in the outpatient setting? So, depending upon how well they're doing from a symptom standpoint, how well is somatostatin analogs working. If the patient has mild CHD, again, you can kind of monitor them for symptoms, give them echoes in every 6 months and kind of keep a close eye on them for that. However, if they're developing symptoms more on the right-hand side here, or based upon their echo surveillance that things are getting worse, especially in some terms of RV dysfunction, this is when you kind of get to more of the right-sided portion here, assessing them for more advanced therapies like we briefly talked about, and then considering them for surgical intervention. So let's go ahead and revisit our patient for one last time here in terms of current management. So based upon that diagram that I saw previously, I would then kind of diagnose this patient with now severe carcinoid heart disease. Now, based upon all the levels with her long-acting lanreotide, she's actually doing fairly well with control of the serotonin. if you look at all of her oncologic notes, she has not actually had any significant additional progression of her of her carcinoid syndrome in terms of the liver. And for what it's worth, it seems like she then has a life expectancy greater than 1 year, which I apologize, I forgot to mention that in terms of surgical intervention, you want to make sure that these patients kind of have that with regards to, the overall benefit, risk benefit in terms of, kind of what are we providing really for this patient. So she has her outpatient cardiology follow-up next in February on the 8th coming up here. So I would say that, depending upon her goals of care and how she's looking at that time, I don't think it'd be unreasonable to consider her for a surgical evaluation for some valvular repair. So we'll see what comes up next within the next month or so. All right, finally, some take-home points, especially for my co-fellows here. So carcinoid heart disease, or CHD, most commonly occurs as a result of metastatic spread of these neuroendocrine tumors to the liver, primarily from the distal small bowel. And again, will primarily affect the right side of the heart with regards to the tricuspid valve and then the pulmonary valve. And this is due to serotonin overexpression by these neuroendocrine tumors and the deposition of plaque-like material on the leaflets, most notably the tricuspid valve and that subvalvular apparatus, leading to thickened, fixed, and retracted valves, causing progressive right-sided dysfunction, mostly regurgitation. Catching CHD early on is incredibly important because it's a major source of morbidity and mortality for these patients. And early detection and surveillance helps them with management options, prognosis, and quality of life. Somatostatin analogs are the first line of therapy for patients with carcinoid heart disease and helps limit the progression. Echo transthoracic is the absolute gold standard in terms of ease of use and primary diagnostic, evaluation, severity, and surveillance of CHD. And again, surgical valve replacement is one of the by far most important interventions for these patients in terms of their advanced CHD, especially in the setting of worsening right-sided enlargement or dysfunction or right-sided heart failure type symptoms. So I want to thank Dr. Thames for all of his kind of mentorship and guidance through not only in the additional suggestion of this topic that we saw when we were looking at all of our echoes and everything together when I was on wards or consults at Grady back in December. So I want to thank him for helping me through this full presentation here. Dr. Ho, who was on echo at that time, was able to go through her echo and read this initially. So I want to thank her for all of her work in terms of that. And then I want to thank Dr. Wenger, Dr. Olomokot, and Dr. Tibet for their continued care for this patient in the outpatient setting. These are my references here, and I'd be happy to take any questions regarding this topic. Thank you for your time this morning.
All right, thank you. Yeah, very good. Nice review. Carcinoid's a classic, and those Doppler images were pretty cool, both of that. Like you showed that triangular, and you even starting to see a little bit of that triangular TR Doppler signal on that first echo you showed. And then obviously by the second one, you had full, pretty much equalization of pressures, between RV and RA and Sicily. And then that sort of, that pulmonic regurgitation with equalization, sort of in mid diastole is pretty cool as well. The issue I've seen in taking care of a few of these patients is, it's very tricky when to operate on these folks. Like as in this lady, you're talking about how she seems to be doing well clinically. Her RV seems okay. Generally speaking, it seems like when these folks do get valve interventions, probably the RV generally seems to be sicker than we think it is, because of all this TR is sort of artificially making the RV seem better than it is. And then there's probably generally also been some, myocardial, endocardial, damage to the RV from the serotonin syndrome. So, I don't know if you have any thoughts on that. Instead of I'm not sure RV function is a great tool. Maybe RV size might be, maybe a better indicator of when it's time, versus clinical status, et cetera. But just thoughts you might have on that particular phenomenon.
That's a fantastic point. It kind of highlights how difficult it is and how much, as with a lot of different kind of syndromes, that with everything being on a spectrum, it's hard to know, especially for something that's invasive or as serious as a surgical intervention, when do we pull that trigger? What parameters and values do we use? Like you're saying, the RV function can be kind of difficult to evaluate. Should we be using like RV dimension? Should we be making sure that these patients all get cardiac MRs in terms of really trying to define and get a better clinical picture as best we can in terms of how well that RV truly is doing? I think the one thing that we do know so far, though, is that there is a clear and massive benefit in terms of patients who do end up getting surgical intervention, which, versus ones that don't. For the ones that then, maybe we feel a lot more confident that they truly are ready and need to have this valvular repair. So I will say, while it's kind of complicated and tough and difficult to sort of determine when to pull this trigger, I think trying to make sure we pull that trigger not too late is incredibly important here too as well. So frequent follow-up for these patients, and I think echoes based on the surveillance time periods that we mentioned, and just truly seeing how these patients are doing, especially symptomatically, will help kind of guide you in terms of, in addition, of course, to our other colleagues' help in terms of CT surgery and oncology and everything else like that, as to when we really should kind of be helping these patients with these valvular repairs.
Good talk, Ryan. Stan Sherman. I'm just trying to figure out, in terms of this patient, was there a lot of medical therapy going on that she did so well? In other words, was she getting a lot of medication throughout her course?
Mm-hmm. So unfortunately, she kind of was intermittently either lost to follow-up through us within the Grady system, or was kind of, I saw some notes from other kind of hospital providers or healthcare systems or two as well. It seems like she has been on this long-standing octreotide therapy for as long as she can remember, and has done fairly well with that. I think she was one of the patients who, kind of looking at one of the earlier slides here, where I mentioned like even 60 to 70% of patients who have these somatostatin analogs will do fairly well with them in terms of really decreasing that serotonin level to less than the 300 micrograms per liter here. And so I think that, as my best guess, that maybe the reason why she was doing fairly well enough on with that is that, maybe her carcinoid syndrome was caught early on enough and treated early on enough to the point of getting those serotonin levels to the as kind of low as possible, in that while we still saw, unfortunately, some decent right-sided heart disease, especially early on in 2014, that maybe through the combination of everything I previously mentioned earlier, that she was able to kind of have this slowed down as much. In terms of those other additional therapies, I did not see anything from the oncologic notes in terms of whether she got any of those like small molecule inhibitors or any sort of like invasive liver therapy specifically. I think because too, when they were looking at the liver, her tumor burden, for her benefit and to our surprise, actually did not seem to increase significantly after it had metastasized from the pancreas. So kind of tough to tell from chart review if she had any of those other additional therapies. I don't think that's the case, but it is still interesting, and can't quite fully be explained in terms of how, for all intents and purposes, she's done so well for so long up until now, kind of this point.
Have they used debulking surgery any, or is that ever recommended to debulk some of the tumor or not?
It definitely is recommended based upon kind of the comorbidities for the patient and sort of how through surveillance this tumor burden is for the liver. I don't think, after looking through her notes, that she had any debulking therapy done. I think they've been continuously evaluating her for that, but I don't think she's met that threshold yet.
Well done.
Thank you.
The preceding program is copyrighted by Emory University.